The first step towards a healthy life is paying attention to our body. To be aware of your own heartbeat is very important. It could reveal abnormalities in the heart rate or rhythm, raising the suspicion of atrial fibrillation. We can control the heartbeat by checking the radial pulse. How to check the pulse? Take a watch and sit down for 5 minutes. In this way, you will measure your pulse while resting. Keep the palm of your hand up, slightly bending your elbow. Put the index and the middle fingers of the other hand at the base of your thumb, between the tendon and the wrist bone. With your fingers, apply a slight pressure on the place where you sense a regular lifting of the skin, corresponding to the pulsation of the radial artery. Count the beats for 30 seconds and then multiply them by 2. That will be your heart rate. How many beats did you count? Normally, the heart rate ranges between 60 and 100 beats, but there may be exceptions. Sometimes the heart rate can be higher than 100 beats per minute or lower than 60. It depends on age, anxiety or stress, physical training, caffeine, medical drugs, and possible other diseases. But when should you worry and consult a doctor? When the heart rate is much higher or much lower than usual? Or when you notice that the intensity of the pulsation is not even. For example, sometimes it is weak and other times it is stronger. And when the interval between each beat continuously changes, it means the heartbeat is irregular. If your heartbeat is too fast, too slow, or irregular, the presence of atrial fibrillation may be suspected and you should consult a doctor for confirmation. The diagnosis can be made by means of an electrocardiogram. In case of atrial fibrillation, the ECG shows the absence of P waves, which are replaced with small, irregular oscillations, the so-called F waves. Moreover, these intervals between two subsequent QRS complexes, so-called RR intervals, continuously change. If you are diagnosed with atrial fibrillation, do not worry. There are several treatment options currently available to help you deal with your problem. First of all, the doctor will choose between 2 treatment strategies: rhythm control or rate control. The rhythm control strategy aims at restoring and maintaining the normal sinus rhythm. That can be done in 2 ways: with cardioversion, allowing the interruption of the arrhythmia, and with medical therapies, preventing the recurrence of atrial fibrillation. The cardioversion can be electrical, through external defibrillation, or pharmacological, through the administration of antiarrhythmic drugs. The prevention of arrhythmia recurrences can be carried out through pharmacological treatments, namely antiarrhythmic drugs, or through a non-pharmacological therapy, that is by transcatheter or surgical ablation. Antiarrhythmic drugs modify the heart's electrical properties, preventing recurrences of the arrhythmia. More specifically, they act at the cell membrane level, obstructing sodium and/or potassium ion channels. This reduces the electrical impulse, and the cells aren't excitable for a longer time. Many drugs are used for this purpose. The most common ones are propafenone, flecainide, sotalol, and amiodarone. But their effectiveness is limited. Fibrillation usually recurs in 50% of cases within a year. Moreover, these drugs may have side effects that can cause more harm than good, and consequently reduce the benefits of maintaining a regular sinus rhythm. They can, for example, create life-threatening arrhythmias and affect the heart's pumping functions. Amiodarone is the most effective among these drugs, even if the harder one to tolerate. It follows that other drugs are preferred at first, and amiodarone is generally used as the second alternative. Recently, a new molecule, dronidarone, has become available, which proved to be quite effective and easier to tolerate. Compared to the other ones, a dronidarone-based treatment has significant effects in reducing the arrhythmia's recurrences, cardiovascular hospitalization -26%, cardiovascular mortality rate -29%, and the risk of stroke -34% in patients with a persistent and paroxysmal atrial fibrillation. An alternative to antiarrhythmic drugs is ablation, a procedure that destroys the areas in the heart where arrhythmia is born and thrives. Ablation can be transcatheter or surgical. In a transcatheter ablation, different catheters inserted from the femoral axis are directed through the vessels to the heart. Catheters get to the right atrium, and after having pricked the septum, dividing the two upper chambers of the heart, two of them are pushed into the left atrium next to the pulmonary veins. At this point, the first catheter maps the electrical impulse from the veins to the atrium, and the second one destroys the area around the veins opening. In this way, the left atrium is electrically isolated from the pulmonary veins, which is the main cause of the electrical impulses initiating fibrillation. Sometimes, as in long and persistent fibrillation, lesions must be created, also in other areas of the atria, in order to prevent the arrhythmia. In surgical ablation, a thoracic cage is opened, or a mini thoracotomy is performed by endoscopic approach. In this case, a catheter is inserted in the thoracic cage to enclose the pulmonary veins, causing a box-shaped lesion. The success rate of this treatment is around 70%, while risks of serious complications are around 3% or 4%. The second possible strategy is rate control. This option is considered when the patient still suffers from atrial fibrillation even after cardioversion attempts. In this case, the rate of the contraction of ventricles has to be reduced to avoid palpitations and the risk of heart failure. This can be done in two ways: through drugs depressing the atrioventricular node, or through ablation and pacemaker implant. Drugs depressing the atrioventricular node slow down or block the passage of electricity from the atria to the ventricles. Ablation, instead, destroys the atrioventricular node, preventing the passage of electricity. The implanted pacemaker is the alternative source of energy, providing electricity to the ventricles and allowing them to function even without natural impulses. These treatment strategies have to be supported by an antithrombotic therapy. As we said before, thrombi, or blood clots, can potentially cause a stroke. To prevent their formation, patients are treated with antiplatelet or oral anticoagulant drugs. An antiplatelet drug commonly used for patients with atrial fibrillation is aspirin, reducing the risk of stroke by nearly 20%. Oral anticoagulant drugs like warfarin and dabigatran are more effective, reducing the risk of stroke by 60%, but increasing the risk of hemorrhages. Your doctor will suggest the therapy that best suits you, considering the type of atrial fibrillation, your symptoms, and the blood test results. Generally speaking, aspirin is given to people who show a low thromboembolic risk, whereas oral anticoagulant drugs are more suitable for those with average or high thromboembolic risk. In patients with atrial fibrillation and high thromboembolic risk, it is possible to occlude the atrial appendage percutaneously by using a device or with surgery. Atrial fibrillation is a widespread problem, often underrated. Its annoying symptoms significantly worsen the quality of life. It can cause stroke, heart failure, and reduce life expectancy. But atrial fibrillation can be fought, and available therapies can solve many of the symptoms, improving the quality and length of life. It is important to diagnose this arrhythmia in time. You can do it yourself by checking the pulse on your wrist and consulting a doctor. If you suffer from atrial fibrillation, your doctor will guide you through some tests and specific treatment strategies. Listen to his or her advice and follow the therapies you are given. And don't forget that there's something precious on your wrist. It's your pulse.